we have the rules set for the judges. So the duration of each paper is going to be 5 minutes. Changing of the presenting author is not allowed. Membership up to 28934 are ratified. So anybody else is considered as non-ratified and not eligible for the award. If there are absentees, please indicate the mark sheet clearly in the absent. Please do not consult your marks with other judges. We highly value your individual evaluation, computation and announcement of results shall be done by the scientific committee office within 2 hours from the completion of the session. So we are not supposed to announce the results. Results announced are subject to ratification by the scientific committee office. Please seal the envelope with the scoring sheet inside and hand it over to the designated volunteer. Who's the volunteer here? Volunteer for the hall? And ensure that the volunteer is sent back to the committee office without delay. So unfortunately, as of now, we have only one speaker. I think Dr. Tanish Garg. Yeah? Why don't you go ahead? We are not able to see anything on the screen, please.
Good afternoon, everyone. My topic for today is approach to dacrocystitis, insight from culture sensitivity and histopathology in DCR patients. Next. It's not changing. It's not working. Change. Objectives. Primary objective of this study to determine the common organism and their antibiotic sensitivity in patient of dacrocystitis who are undergoing DCR surgery. Secondary objectives to formulate a better antibiotic cover for the patient undergoing DCR surgery. Materials and methods. So this is a prospective study. Study population of the patient with NLDO causing chronic dacrocystitis. Duration of the study was 6 months from November 2023 to April 2024. Exclusion criteria of the cause of secondary cause of NLDO block or repeat of failed DCR cases. Sample collection. Intraoperatively during the procedure directly from the sac using sterile cultures where the pus was collected. Investigation culture was done using blood agar, eosin methylene blue, chocolate agar and seborrheic agar. Antibiotic sensitivity were tested using Vitek 2 compact method or instrument. Along with the culture and sensitivity, lacrimal sac flap was sent for histopathological examination. Results and discussion. A total of 45 patients who underwent DCR were analyzed. The gender distribution was 3:1. A total of 35 patients came positive for the culture. And on histological examination, 45 samples showed chronic inflammation. The mean age of 48 years, which was seen in all the previous studies, and the female to male ratio of 3:1 was also seen in previous studies. 13 different organisms were isolated. Among positive samples, 48% of them were gram negative and 41 were gram positive.
Excuse me.
So this is also, it's not working. Among the gram-negative organisms, Pseudomonas aeruginosa was the highest in number, and among gram-positive, it was Staphylococcus aureus. Although gram-positive organism has been reported as a common cause in different studies conducted in different parts of the world and in India also, higher number of gram-negative organisms were isolated in our study, which was similar to the studies conducted in Turkey. Pseudomonas and Staphylococcus aureus were the most common organism in our studies, which has been similar to the other studies. However, in other studies, pneumococci and Haemophilus were also very common, but in our study, we didn't find a good number of these organisms. On antibiotic sensitivity, gram-positive bacteria showed higher sensitivity to gentamicin, trimethoprim, daptomycin, and linezolid, that is 100%, followed by 93% sensitivity to tetracycline and vancomycin. Gram-positive showed least sensitivity to ciprofloxacin and levofloxacin. On 43% were sensitive to these antibiotics. Antibiotic sensitivities in gram-negative show highest sensitivity to cefoperazone and meropenem, followed by 90% sensitivity to amikacin, gentamicin, trimethoprim, imipenem, and least sensitive to colistin and ciprofloxacin, that is 76 and 80% respectively. Antibiotic sensitivity in our study was similar to the trend shown in Turkey and Syed, which was conducted in Lucknow. However, comparing it with studies conducted in Iran, it showed a different trend where the ciprofloxacin is the most sensitive antibiotic along with vancomycin. Conclusion: the bacteria that were most isolated, often isolated from individual with chronic dacrocystitis in our investigation with Pseudomonas aeruginosa and Staphylococcus aureus. The finding demonstrated that quinolones like ciprofloxacin and levofloxacin are less effective against both gram-negative and gram-positive bacteria. Therefore, in our area, individuals with chronic dacrocystitis may benefit more from empirical antibiotic treatment with aminoglycosides and folic acid inhibitors rather than quinolones. Since these studies results are preliminary, further extensive research should be conducted to support them. Patients with chronic dacrocystitis may have changed their antibiotic bacterial profile and resistant to antibiotic over time. They must be under constant observation and supervision. No, ma'am. It was positive in 35. Out of 45, 35 was positive. 10 were not, no growth. No. During this study, we had given before only. We have not waited, but after we will formulate.
So did this study make you change your approach as to which antibiotic
actually
you
we were giving ciprofloxacin more often in our college, so now we will change it to the, because ciprofloxacin showed least sensitivity in gram-negative and gram-positive both bacteria.
So now which one are you preferring?
Now trimethoprim will be a better option.
No, which one do you actually give?
Like we have to start now. Usually we give ciprofloxacin only, but trimethoprim is a better option according to this study, because gentamicin and all are severe toxicity and different side effects also.
Okay.
Have you seen any infections post DCR?
No, sir.
Because what you had put up on the first slide was that you wanted to know what antibiotic to give after DCRs, right? So in spite of ciprofloxacin, you did not have any infections in the wound as such.
Yes.
So what was the point in doing the study for that? It would be more for treating an acute dacryocystitis rather than a perioperative cover, right?
The antibiotic sensitivity might change, and like different organism has been identified in different areas. So in case if there is any complication occurs, so we will be able to have some idea because of which it can occur and what are the antibiotics which are more useful in this.
In all cases of DCR, you have done this culture for the study period, or anything like repeated acute dacryocystitis or something?
Not all. patient undergoing DCR due to traumatic NLDO block or repeat DCR or failed DCR, we have not taken the sample.
Excluded. Mm.
We have any other authors present? What's your? So we'll need to sign here first and then go ahead there.
Anybody else is present? Your name, please.
Can you please come and sign here?
Supriya Sharma.
So all the authors who are available, can they come and sign, please? Thank you.
This is not my slide. Supriya Sharma. Good afternoon all. I'll be presenting a case series showing anatomical and functional outcome post canaliculi involving lead laceration. There are no financial disclosure or conflict of interest whatsoever. Eyelid laceration involving canaliculi has a prevalence of around 10 to 20% in all the eyelid tumors, and the most common modes of injury which we find in Indian subcontinent especially includes blouse hook fastener, animal bite, falls, blunt trauma, and road traffic accident. Patient usually present late, and following delayed repair, there can be presentation with scarring or constriction of lacrimal pathway with lifelong symptomatic epiphora. These are more prevalent in children and young adults according to literature, with males more frequently affected, and surgery involves primary repair along with mono or bicanaliclar stent placement depending upon the involvement. The study was conducted over 6 months period. Patients with eyelid laceration and canalicular involvement were operated by the same surgeon at our institute. Distal cut end was identified as pinkish white mucosal structure, and Bowman's probe was used to look for hard stop through the punctum. Monocanalicular stent was used and pericanalicular suturing was done. Stent removal was planned at 3 months followed by syringing to look for the anatomical and functional outcome. Anatomical outcome was observed with respect to structure integrity and patency of nasolacrimal duct, while functional outcome was observed with respect to absence of epiphora. Coming to our first case, the patient was 24-year-old male with left eye upper and lower lid laceration due to dog bite. He was primarily treated within 24 hours, and monocanalicular stent was implanted. After 3 months, we removed the stent and syringing was done, and it was successfully operated with no regurgitation of fluid that was noted. Coming to case 2, she was a 40-year-old female with right eye lower lid tear following RTA. Patient was primarily treated and stent was implanted, and after 2 weeks the stent was in place, and 3 months follow-up is still pending. Case 3, 4 and 5 all are kids with lid tear basically due to blouse hook while breastfeeding. In case 3, the patient was taken up within 2 days of presentation, and on last follow-up in both case 3 and 4, the stent was in situ. While in case 5, he was a 2-year-old male following blouse hook while breastfeeding. He had left eye lower lid tear, and at 2 months of follow-up, the stent was not at place. It was extruded. Case 6 was 13-year-old male with left eye lower lid laceration while he got it while playing, and a stent was removed at 3 months, and no regurgitation was noted following syringing. Similarly, case 7 and 8 had similar outcomes with no complaint of epiphora. We observed that canalicular involvement was more so in lower lid injury compared to upper lid injury, and was more common in males than females in our series, and children and adolescents were more affected as compared to adults. There were 4 toddlers who had injury due to blouse hook fastener that is unique to Indian subcontinent. Presentation and subsequent repair was done within 24 hours till 5 days, and edema and inflammation was more common in late presentation, which posed difficulty in finding the canaliculi and stent insertion. Therefore, stent removal, as we can see in our results, that stent removal was done in 2 patients at 3 months. On syringing, no regurgitation of fluid was found in 2 cases, and it was successful. In rest, a stent was in situ till last visit without complaint of epiphora. Based upon the literature research, lacrimal canaliculi lacks tarsal substructure, therefore, it has a greater risk of damage when displacement from the medial canthal tendon increases. Preferably, the repair should be done within 3 days of presentation, but there are no clear guidelines as such, and methods for locating canaliculi are many, out of which we use pinkish, whitish elevated tubular structure as landmark. Otherwise, we can also do fluorescent dye injection, air bubble injection, fiber optic, light probe can be used, or pigtail catheter can also be used. There are certain related research works which we used in our study and concluded that repair is a skillful surgical intervention, and early repair is a must to prevent placing the canaliculi stent, and meticular tissue apposition improves cosmesis. Awareness regarding safe breastfeeding is must in Indian subcontinent. Thank you.
You haven't mentioned which suture was used?
Sir, for tarsal and muscle suturing we use Vicryl, and for skin we use silk basically.
And pericanalicular tissue?
So same Vicryl.
Which Vicryl? 60?
60 Vicryl.
Have you got any relationship regarding the location of the tear? I mean, distance of the tear area from the puncta, or
Sorry, ma'am?
prognostically, have you got any relationship regarding the location of the tear? Okay, I mean whether it is a proximal canalicular tear or intermediate or distal. Is
No,
there
ma'am,
any
not done
difference
this.
in outcome
Ma'am,
in finding the number 1, the other end of the canaliculus, and placement of the tube? No,
ma'am, we have not done
you have not done
that
that.
in this study.
But all cases I see is not in the distal end.
They were mostly in the proximal or
proximal end. They
intermediate
are
part.
in the proximal end.
Mm.
All cases location
Similar
is similar.
cases were present,
Okay.
ma'am.
Okay.
You have said that you assess the functional outcome by the absence of epiphora. So you presented cases in which they were children. So how did you assess that? And secondly, anatomical assessment you said you did by syringing. But you presented cases in which the stent is still in situ and there are children. So did you do syringing?
Ma'am, not for kids, because we one of them was lost to follow up, and the other one we have to take them under GA. So
So
many
did you-
times patients.
No, out of your series, in how many were you able to do it, and how many you had not done it?
Ma'am, amongst 4 children, one was lost to follow up, and one of them was taken up for under GA.
For
Otherwise,
syringing?
no. Yes, ma'am. For
And-
GA, just to relocate because stent was not there.
So
Stent
we-
was extruded. Therefore, we took again under GA to see the patency.
So did you re-stent
For
it?
yes, ma'am, to see where the stent is actually, because they didn't complain of any extrusion as such. Otherwise, we don't take kids again and again for GA. Thank you, ma'am.
A very good morning to all of you. I'll be speaking on a comparative study of the dacryocysto-rhinostomy with mitomycin C versus dacryocysto-rhinostomy with intubation. Embryologically, the lacrimal drainage apparatus starts developing by the end of 5th week and completely canalizes by the end of the birth. Anatomically, when we see the lower end of the nasolacrimal duct, when it's obstructed, gives rise to epiphora. So the gold standard method of this, gold standard surgery to deal with this is the conventional method of dacryocysto-rhinostomy. But there have been many various modifications with this conventional method. Although the failure rate of the with the conventional method is of DCR is 10 to 15% due to many reasons, being fibrosis, scarring, and granulation tissue at the site of osteotomy to be the most important factors. So to increase the success rate, there have been use of many adjunctive method in the recent past, like the use of silicone tubes and mitomycin C. So in our study we have seen the efficacy of these two procedures. The mitomycin C, being an alkylating agent, inhibits the synthesis of collagen and proliferation, helps reduce in the scarring and excessive fibrosis and adhesion at the operative site, which has been also shown by study by Semasari et al. And Shulau et al. Silicon tube intubation enhances the lacrimal pump function and increases the lacrimal tear drainage by increasing capillary action and helps in guiding the canicular epithelium to progress further. This has been seen as study done by Kim et al. So our chief objective was to compare the surgical outcome and efficacy of both these procedures and to compare the learning curve and compare the average time consumed in this procedure. The place of study was ophthalmology OPD of NRS Medical College and Hospital, Kolkata. It was a 1-year long study, observation, longitudinal and comparative type of study. The 100 patients were selected who were randomized into 2 groups with MMC in group A and intubation in group B, and they were followed up in 1st, 3rd and 6th month, and all the surgeries were done by a single surgeon. The inclusion criteria included all confirmed cases of primary nasolacrimal duct obstruction within 15 to 65 years of age group, and we excluded all cases of congenital, traumatic, infective, malignant and causes of nasolacrimal duct obstruction, any previous history of endonasal DCR, laser DCR or any pre-existing nasal pathology were also excluded. We used students t-test and chi-square test for comparing the 2 groups. Pre-operative preparations were done and conventional type of DCR surgery was done up to the making of the osteotomy and creating H-shaped flaps, and the smaller posterior flaps of both the lacrimal nasal mucosa were cut in all the cases. In case of group A, the mitomycin C was applied using cotton pledgets for 2 minutes and thorough washing was given. In case of intubation, 27 gauge silicone tube was used, 3 knots were applied at the end and the tubes were removed after 6 weeks interval. The post-operative outcome was seen after 6 months. The results shown that the chi-square test came out to be 0.955 with a p-value of 0.045%. This is the graph showing the gender distribution. Here we can see the females were more included in our study. The age-wise distribution in both the cases, 45 to 55 years of age group were more included. The success rate in case of DCR with MMC came out to be 92%, and that with silicone tube came out to be 96%. This is a graph, learning curve showing the number of complete procedures done by a single surgeon in months. Here we can see the operation with MMC could be done by the same surgeon within 2 months, whereas it took almost 6 months to learn the surgery involving silicone tube due to its technical difficulties. This is the average time taken to complete the procedure by the same person. Here we can see the total maximum number of surgeries involving MMC was completed within 30 to 40 minutes by the surgeon, whereas the same surgeon took around 60 minutes to complete the surgery with the use of silicone intubation. The causes of failure in our cases was with MMC 8% and with silicone intubation 4%. With MMC it can be due to profuse bleeding leading to washing of the MMC from the site of application, or technical difficulties, or traumatizing the nasal mucosa while applying the MMC. In case of silicone intubation, it may be due to granulation tissue formation at the site of knots or trauma during the procedure. So in case of conventional method, the successful outcome is almost 85 to 90%, but with the use of MMC or silicone tube, the success rate increased to 95 to 98%. These are few of the studies which we have compared with our study. To conclude, the surgical outcome and efficacy of both the techniques are at par with each other, but the learning curve of DCR surgery with silicone tube intubation is obviously prolonged and requiring more expertise, and also the average time taken to complete the silicone tube intubation surgery was more than with that of the MMC. The limitations are study-wise. It was a small sample size with restricted age group within 15 to 65, and a short follow-up period of 6 months was done, and obviously it was a single institutional study. Thank you.
At what stage did you apply the MMC? At what stop of the
After
DCR?
creating the osteotomy and making the H-shaped flaps, after that we applied the MMC.
Where exactly did you apply?
At the osteotomy site.
At the edges of the osteotomy site?
Yeah,
you
ma'am.
mean?
Yeah.
Okay. What was the concentration that you used each time?
We used
or was the
0.2
same?
mg per ml.
For how many minutes?
2 minutes, ma'am.
Each time?
Each, yeah.
Okay.
It was a single flap technique for you, or both the flaps you had?
Ma'am, sorry?
Single flap technique or both the flaps? Superior and inferior, nasal mucosal flaps?
Ma'am, both the flaps.
Both the flaps.
So what would you recommend? Based on your study, would you
Yeah.
recommend surgery with MMC, without MMC, or
So,
with
ma'am,
intubation?
it obviously depends on the surgical expertise, because as I have shown in my study that the surgical expertise for doing a silicone tube intubation is much more than that of the MMC, where we only apply cotton pledgets. So if the surgical expertise is at par, we can use any of the method depending on the cost effectiveness, because silicone tube intubation obviously costs more.
Okay, so you would not recommend doing any DCR without MMC?
No, ma'am, obviously I would recommend, because the outcome is good with the MMC only rather than conventional methods.
Can you quote any study in which it has been done, a primary NLDO, in which a conventional DCR is done versus a DCR with
Ma'am, there have
MMC?
been many studies. I have mentioned in Canacillo et al. that the study was done using MMC in primary NLDO just to see the efficacy of the MMC.
Now, the complication rate is more with the intubation. Have you studied that?
Ma'am?
The
Yeah,
complication
ma'am, the
rate
complication rate is definitely, I have not
is
shown
because
the
of the granulomas,
Yeah, ma'am.
infection, patient
Ma'am,
has
I
to
have
follow
not
up,
shown
not
the
coming back for
complication.
removal. So, in cases of primary NLTO, how frequently would you recommend doing DCR with intubation? All these were adult patients?
Ma'am, 15 to, yeah, on adult patients, ma'am.
That's what I'm asking. How frequently would you recommend doing DCR with intubation?
Ma'am,
In a
if-
primary, not in a failed DCR or pediatric DCR.
Ma'am, that too, it depends upon the surgical expertise after all.
What was the time frame in which you removed the silicone tubes?
Sir, in all the cases, we removed it within 6 weeks of enter. Thank you.
Any of the presenting authors are available?